Good afternoon, everyone.
Good afternoon, sir.
Good afternoon, Sandeep. How are you?
I'm good, sir. How are you, sir?
Fine, man. So I welcome all moderators and participants to this Televersity today's live workshop program. Today we are going to show about that safe laparoscopic cholecystectomy. This laparoscopic cholecystectomy is one of the most common general surgical procedures, but it's a daycare procedure. So it's basically, if you do it in right way, safely, patient can be discharged within 24 hours. But doing safe laparoscopic surgery is most important. If you do any complications during cholecystectomy like bile duct injury, vascular injury, the complications leads to the quality of life of that particular patient compromised significantly. The treatment cost is going to increase many folds. And another thing is a medical legal issue. So that's why we chosen this topic to show that how laparoscopic cholecystectomy to be done safely. Now I am going to my presentations. Today we are planned to do 2 or 3 laparoscopic cholecystectomy, then 2 lectures. In that first lecture is this is how to perform safe laparoscopic cholecystectomy. Already I told it's a most common surgical procedure done by both general surgeon and HPV surgeons and a daycare procedure, but doing the surgery safe is most important. For that, the surgeons should know the anatomy of that particular regions. Then not only depends upon the knowledge of the doctors, but also depends, this is basically technology based surgery. So technology also is, you should have very good monitor, cameras, everything, instruments. We are using energy sources, so the thermal injury should be avoided. So the instruments also very important. The another thing is you should anticipate the difficult cases preoperatively through the investigations and the history taking, proper physical examinations. If you want to do laparoscopic cholecystectomy in safest way, you should follow the concept of critical view of safety. This critical view of safety, nothing but it contains 3 components. If you are able to achieve the critical view of safety during laparoscopic cholecystectomy, then the lap cholecystectomy is done safely. What are the 3 components? If you ask the many surgeons about that critical view of safety, only 1/3 of the practicing surgeons knows about that this CVS. In that, how many of them following during laparoscopic cholecystectomy? Less than 10%. So we have to give importance to the critical view of safety while doing simple gallbladder surgeries, because in complicated cases sometimes it's very difficult. So achieving the critical view of safety is possible only 85 to 90% of the laparoscopic cholecystectomy cases, not on all cases. So coming to the critical view of safety, this was described by Strasberg in 1995, because after the introduction of the laparoscopic cholecystectomy in 1990s, the incidence of bile duct injury, vascular injury was higher than that open cholecystectomy. So then Strasberg and other international faculty, they want to reduce the incidence of bile duct injuries. So Strasberg introduced this critical view of safety in 1995. So in this critical view of safety, it contains 3 components. These 3 components are important. Many surgeons don't know about it. It contains 3 components. Sometimes they'll think about only 2, but it's actually 3 components. First one is clearance of the hepatocystic triangle of all adipose tissue and fibrous tissue. So you should remove all the fibrofatty tissues within the hepatocystic triangle. Then removal of gallbladder from the bottom 1/3 of the cystic plate of the leg. This is most important. Removal of gallbladder from the cystic plate lower 1/3. Why we are doing means sometimes bile duct anomalies will be there. Cholecystohepatic duct will be there. So the lifting of the gallbladder from the bottom 1/3 of the cystic plate is very, very important. That will give wide space. You can say that, then only you can say that satisfactory critical view of safety is achieved. After doing these 2 things, this is the visual analysis. That means 2 or only 2 structures either entering the gallbladder or leaving the gallbladder. That means only cystic duct and artery. So coming to the hepatocystic triangle, it's bounded medially by common hepatic duct. This is hepatocystic triangle. In this hepatocystic triangle, medially it's formed by that common hepatic duct, laterally cystic duct, and superiorly by undersurface of the liver. So this is the hepatocystic triangle. So if you clear all the adipose tissue in this area, you can see only two structures, only the cystic duct and the cystic artery. Coming to the mechanism of the classic injuries. See, nothing but after dissection of the, it's not a complete dissection of the hepatocystic triangle, it's an apparent hepatocystic triangle. You are seeing the only two structures. But if you see that, it's the, when you see first time, you will think about this is the cystic artery and cystic duct. This is the perception, these injuries happen due to the misperception of the anatomical structures. What surgeons perceives after doing this incomplete hepatocystic triangle dissection, he perceived this cystic artery, as I already told, it is cystic duct. But actually what happened, the dissection happened left side of the CBD. So the dissection happened left side of the CBD. So due to inadequate dissections, this is the right hepatic artery, this is the CBD. So these misinterpretations, misperception of the anatomical structures, so these two structures considered as cystic duct and cystic artery clipped and divided. This is the major cause for that bile duct injury and vascular injuries. Other reasons are local anatomical factors. When the gallbladder is inflamed, it's hepatocystic triangle, that means callus triangle is fibrous because of recurrent infections or anomalies of the anatomical structure. This also will lead to injuries. Then importance of the second and third criteria of the CVS. So I already told second criteria is lifting of the gallbladder from the cystic plate, and third is the only two structures should be entering or leaving the gallbladder. So injury can be avoided, but ensuring that only two structures entering or leaving the gallbladder. Any more structures entering or leaving the gallbladder, then you have to dissect some more above or below, then you have to confirm it, it's not the anomalies, then only you have to do that. So this is the anterior view of the cystic plate, this is the posterior view of the cystic plate. So this is most important. Then only you can say this, I am achieved the satisfactory critical view of safety. That means 1/3 of the cystic plate must be exposed both anteriorly and posteriorly before any structure clipped and divided. Coming to the next is the cystic duct. This, while doing laparoscopic cholecystectomy, the dissection always started at the junction of the infundibulum and cystic duct, not the cystic duct and CBD, because this is the dangerous zone, this is a safe zone. So initial dissection started in these regions, anterior peritoneum is divided, posterior peritoneum decided. So if you start dissecting here, the chances of bile duct injury will be more. So coming to the cystic duct junctions with the CBD, there are three possibles. Most common is angular. It usually joins with the right angle to the CBD's CHD. Second one is that it has long course of that cystic duct which goes down to the insert to the lower end of the CBD. This is called parallel one. Very rarely it goes behind the extrahepatic bile duct system and join to the left side of the CBD. So these two things should be very careful while dissecting, because the chances of injury to the bile duct is more. So that's why whenever you are grasping the infundibulum, should be traction given toward the inferolaterally. So cystic, that hepatocystic triangle will be opened up. This becomes a right angle to the bile duct. So chance of, when it's parallel to the bile duct, the chance of injury will be more. Then this flare up, that flare identify the cystic duct and infundibular junctions. Sometimes this is mistaken when the stone in the cystic duct, it's blocking the cystic duct. It causes the dilatation of the cystic duct. Because of the blockage of the cystic duct, it causes dilatation. So the mistakenly taken as this is one is infundibulum and cystic duct junction. So while dissecting here, the chance of bile duct injury will be more. So the identifying the cystic duct and infundibulum junction is more important. In the absence of cystic duct stone, preoperatively if you see the ultrasound, there is no cystic duct stones, then that flare is usually indicates the infundibulum and cystic duct junction. If any stones in the cystic duct, it causing dilatation, then it's identifying the flare, that funnel shape doesn't mean it's infundibulum and cystic duct junction, it may be cystic duct itself. Coming to cystic artery, because knowing the anatomy is most important to avoid the unnecessary complications, because in this region the anatomical variation is very high. Next is the cystic artery. Usually cystic artery arises from the right hepatic artery. Usually it's a single artery. It divides near to the gallbladder wall into two branches. One is the superficial and one is the deep. Sometimes the division happened little earlier, so it gives multiple branches. Two branches will go. So if over that cystic artery there is node called cystic node. So whenever you are dissecting the cystic artery, the dissection should be happened above the node, not below the node. If you do the dissection below the lymph node, the chances of right hepatic injury will be more. So whenever you are identifying the cystic node, the dissection always above the cystic node, not the below that. Coming to that branches, already told, it usually single artery from the right hepatic artery. It divides into two branches when it reaches near the gallbladder wall. But sometimes it divides earlier, then two branches will be there. Sometimes multiple branches will come from the right hepatic artery. So whenever you dissect the gallbladder, always hug the gallbladder wall, but without injuring that. So if you do dissection near to the gallbladder wall, the chances of injury to the right hepatic artery will be very, very less. In case replace right hepatic, when you are seeing that cystic artery below the cystic duct, so chances of replace right hepatic artery. So whenever that replace right hepatic artery gives the cystic artery, usually it goes to the gallbladder just inferior to the cystic duct. So when the cystic artery is below the cystic duct, so it's maybe the associated aberrant right hepatic artery. So when you are dissecting posterior to the bile duct, should be very, very careful. Very rarely that right hepatic artery form the hump or tortuous hose in the hepatocystic triangle. This is called Moynihan hump or caterpillar. So here that cystic artery will be very short. So the chances of injury to the right hepatic artery is very, very high. So that's why always hug the gallbladder wall to avoid the injury to the right hepatic artery. So I already told it's not only depends upon the anatomy of the particular region, also the surgeon's performance, means the retraction of the gallbladder. If you do the right way tractions, means fundus should be retracted towards the right shoulder of the patient. That means superiorly and laterally. Then infundibulum should be retracted inferiorly laterally. So that means it's elevate the gallbladder little higher up, and the hepatocystic triangle will be wide open. That gives space to dissect adequately. That cystic duct also becomes right angle to the bile duct. When you are doing anterior dissections, we are incising the anterior peritoneum, medial dissections, the infundibulum should be retracted downward and outward. When you are doing posterior dissections, infundibulum will be retracted superiorly and medially towards the umbilical fissures. If you are not given adequate track, means you are the infundibulum not retracted inferiorly laterally, you are giving retraction to superiorly, the cystic duct will be near to the bile duct and parallel to that. So you think about this segment. If you start dissecting little lower, you think about this bile duct will be the cystic duct. The dissection will happen all around that. Then chances of bile duct injury will be more. So always, while dissecting anterior part of the medial dissection, the infundibulum always retracted downward and outward. That's the most. Then only the hepatocystic triangle will be open. So some landmark before dissection should be seen. This is medial to the gallbladder segment 4, lateral to that segment 5. This is that hilar plate. This is the confluence of the right and left hepatic duct. This is the hepatoduodenal ligament. This is common hepatic duct. That right posterior pedicle, right pedicle or right posterior pedicles is the ruveus sulcus. This is the base of the segment 4. This is segment 4. This is the base of the near to the hilar plate. This is the base of the segment 4. Because in acute phases, this anatomic landmark is important for doing the safe cholecystectomy. The ruveus, coming to the ruveus sulcus, one of the most important landmark for that any bile duct, any hepatobiliary surgeries. Because if you want to do safe cholecystectomy, your dissection always should be above the ruveus sulcus. If you are going below, means that is the dangerous zone. So ruveus sulcus seen only in 80 to 90% of the cases, not in all cases. So, but this is one of the important landmark to perform the safe laparoscopic cholecystectomy. I already told it contains right hepatic pedicle or right posterior pedicle. So another landmark is base of the segment 4 at the level, mark the level of the hilar plate. So if you draw the line from the roof of the ruveus sulcus along the base of the segment 4 towards umbilical fissure, this is called R4U line. So whenever you start incising the peritoneum, the peritoneal incision always above this line. This is because starting from ruveus going across the base of the segment 4 and reaching the umbilical fissure. So R segment 4U, R4U line. So this is the most safest zone to start the gallbladder surgeries. Coming to the plane of dissections, after that, while removing the gallbladder, always start dissecting between the two layers, mean cystic plate and the gallbladder wall. But if you see the gallbladder subserous layer, it contains two layers, inner layer and outer layer. Inner layer is most vascular layer, outer layer is fatty layer. So if you go in this plane, the chances of bleeding will be less. So your dissection always between the cystic plate and the gallbladder. If it goes deeper to the cystic plate, the chances of bleeding and bile leak will be there, because sometimes subvesical bile duct will be there. So if you injure this, the chances of bile leak, sometimes sinusoids will be there, or middle hepatic vein tributaries will be there. So if you injure this structure, the bleeding will be very torrential, so difficult to control. So always goes between the cystic plate and gallbladder. So coming to the roadmap for cholecystectomy, while performing critical view of safety, are you able to achieve it satisfactory? That's I told, three components should be there. All fibrofatty tissue in the means critical view of safety should be removed adequately. Then lower 1/3 of the cystic plate should be exposed. Only two structures should enter the gallbladder. If you establish the CVS, then before clipping the structures in time out. Time out means that's a momentary pause. Yeah, then you have to see the structures anteriorly, posteriorly. Then if you have any doubt, you can ask your colleague. Then after that only you have to clip the two structures and divide it. If you are not able to achieve the critical view of safety, then you can get the opinion, or you can use the additional investigation like intraoperative cholangiogram or ICG or laparoscopic ultrasound. Then you are not able to identify the structures properly, then bailout procedure is a better choice. Bailout means either you can do laparoscopic subtotal cholecystectomy or cholecystostomy or conversion to open. Thank you.
Dr. Nalankali, am I audible?
Yes, Manoj.
Yeah. Oh, very nice talk, sir. Very nice talk. From the
Thank you.
basics to the extent. So, how are you, by the way? Doing fine?
Fine, doing good.
So,
How
when
about
do
you?
you, just one question to you, when do you decide on doing intraoperative cholangiogram?
Ideally speaking, I never did any intraoperative cholangiogram. I am here in 14 years. But intraoperative cholangiogram, whenever you are having anatomical, not able to identify the anatomical structures because you are bile duct injuries. So by doing intraoperative cholangiogram, the chances of detecting the bile duct injury is higher than the not doing.
Sir, similar question. Excellent presentation, Nalangili sir. A lot of basics again revised. One small question is those surgeons who are practicing in periphery, especially don't have facilities of say intraoperative cholangiogram as well as ICG for identification. What would be your suggestion when surgeons feel it is really difficult to proceed with cholecystectomy at that point?
Okay, he is having suturing skill. Then we can go for subtotal. You divide the gallbladder in
Sir.
middle also, no issues. You can take down you can divide the gallbladder little. You divide initially just above just below the middle of the gallbladder.
Sir.
Means above the ruvius case. I told no R for U line.
Yes, yes, sir.
Not able to see R for U, just you divide just below the middle of the gallbladder. Open the gallbladder, then you cut the gallbladder towards the cystic duct area.
Duct insertion, yes.
Then you can dissect all around it. In case posterior wall densely underground, leave the posterior wall. You can dissect submucosally also, leaving the part of the gallbladder along that hilar region. You can elevate the mucosa, submucosa. Then you can form that funnel shape like structure. Then you can put the loop or suture it.
Perfect, perfect. I think this is very important point for all those audience and are new surgeons or in their initial part of their career. Sir has described the same technique which we followed in GEM Hospital as well. You cut above the infundibulum or in between. You can cut in between the body of gallbladder, come down along the gallbladder wall. Try to minimize the dependent area where your portion of gallbladder would be minimal. So I think sir has highlighted very important point. For those surgeons who are working in periphery with limited gadgets and limited availability of even seniors for that particular matter, if there is no help available, no senior surgeon would be available or any colleague is available, I think this is very, very important technique highlighted. Thank you, sir. Thank you.
Yes, and the relieving gallbladder is not the issue, but injuring the CBD is most dangerous.
Yes, very, very important. Yes, sir. Yes, sir.
That's true.
Certainly, I agree.
That's a very important.
Good afternoon, Dr. Nalangiri. I am Jugindra here.
Very good
Excellent
afternoon, sir.
presentation and a very nice basic description of the safe lab chole. I think those steps were very standard and should be followed very nicely. I have one question for you. You have very nicely pointed out that the dissection of the artery should be above and lateral to the lymph node if it is seen. So what we have encountered is that at that point, basically the artery is already divided into two, the deeper one and the superficial one, which you have demonstrated. So what we are going to encounter is the superficial branch usually at that point.
Yes.
So if we clip that and then think that we have clipped the cystic artery, is there a chance for the deeper one to be not clipped and then cause bleeding?
Yes, sir. While this is happening, if you are not clipped that deeper branches, while lifting the gallbladder from the cystic plate, where you will encounter that deeper branches, if you injure that, then the bleeding will be there. So you can put the clip or bipolar that area. If
Right.
you clip that common, cystic artery, then the chances of the posterior deeper branch also will be taken care. But
Yes.
Yes, you said only the superficial branch is only clipped. Then if you are hugging the gallbladder, the deeper branch will go down. So while
Yes.
lifting the gallbladder from the cystic plate, then higher level, then where it's going to enter the gallbladder, then you will, in that area you will injure or you will cut the artery. So where you can apply bipolar or most safest way you can put the clip also.
Right. So that's why if we dissect the vessel above and lateral to the lymph node, which is correct and which is more safe for the injury of the CBD, to prevent the injury of the CBD, if that is the case, then we should be prepared to find another vessel going posteriorly and deep. So that we have to keep in mind. That's what I wanted to point out. Nice presentation.
Thank you. So now Chief is ready in OT, so we can go
Yes.
for live surgery.
Case, yeah. we
Thank
can-
you.
Certainly. Thank you, sir. Thank you.
Okay. Hello. So today we will be proceeding with our first live case. This is a 65-year-old male came with the chief complaints of upper abdominal pain with bloating and belching associated with issue of vomiting. Patient had a history of TB or BT in the past with no significant medical comorbidities. General physical examination was normal. Per abdomen findings, the patient had a significant tenderness in epigastric and right hypochondriac region with Murphy's sign positive. These are the ultrasound findings. Patient had a distended gallbladder with a wall thickening and surrounding fat stranding with a doubt of common hepatic duct calculus. But we did MRCP, which was suggestive of acute calculus cholecystitis with type 1 Mersey syndrome, slight indentation of GB neck with the common hepatic duct. So LFT normal with normal bilirubin levels, OTPT levels normal with normal total counts. So this is a case of acute calculus cholecystitis with type 1 Mersey syndrome. Thank you. Plan is lap cholecystectomy.
இந்த லைட் ஆஃப் பண்ணி பார்க்கலாம் அப்பதான் நீ காமி
Good afternoon, sir.
Good afternoon.
Very good
Beginner
afternoon.
here, sir.
Yeah, nice
Good afternoon, sir.
lecture, and I listened to all of your talk about the off பண்ணுங்க light off. Okay, are you getting you are able to see the patient, and we are all standing here?
Yes,
Yes,
very,
sir, yes.
very well.
Yeah, patient is supine, and I'm on the left side of the patient, cameraman on the left side, and staff nurse on the right side. Second assistant, you want to do opposite way, you can stand. Generally, in the beginning, 2 monitors, we always keep it one right shoulder, another one left shoulder. But generally, we are all practicing with one camera, it is enough. And now, let me talk about a minute or two regarding the port placement, making it a safe lap chole. In the light, now, this is a head end. This is zipper process. You can appreciate this symphysis pubis. Now he put 2 fingers. The umbilicus is not in center. It is very low place. Generally, we call periumbilical is the camera trocar. That is what the teaching in the beginning. But the most important is to a midpoint of the midline. If you take a midline, then hilum will be seen well. Suppose in case if it is a scar, otherwise also, see, look at, because here, this is adequate distance there here. And this is acute gallbladder. Always generally try to, under relaxation, do like this. That means some flimsy adhesion is there, it will get separated if you want to go there. Suppose a star there, patient had acute pancreatitis before, then that adhesion will not go, you can't do that. So what you have to do, those cases you can palmar point, take a 5 mm scope if you have, put a pneumoperitoneum through this, under guidance you can make it the working trocar. Suppose if this case for me looks like a straightforward, I am choosing the midpoint here, and we can appreciate this is a camera trocar. This is 10 mm. Then subsequent working trocar should be like 5 centimeter below the liver edge. They generally will take it right hand working. Right hand working is 10 mm. We can use a clip, we can use a gas piece, we can take switches, everything we take inside. And 2 more working trocars, the right midclavicular point, you can see the costal margin here, just below the costal margin, I keeping it. Should not 2 go, very difficult to work. See now, I am making a 5 mm. Similarly, this is for left hand working. I am making it as anti-axial line. Here it is a 5. This will be used for grasping, retraction, drainage tube, anything we can use it there. This is left hand working. This is called 4-port technique. And camera here, right hand working, midclavicular this. But this will be not, we can't decide because the exact liver location we don't know. But camera trocar is one thing we have to divide. Under guidance, we'll make this trocar. It may go the same level which I shown or not. Now I'm this way. And entry into the abdomen can be many ways. One is by close varus needle technique. Another is suppose obese abdomen, you can't go with that. And a needle you can, long needle you can use, or Visiport you can use it, get into the abdomen. And no open laparoscope, generally it is a standard approach, but open laparoscope is difficult to go, very thick abdominal wall. Straightforward cases, okay. Now I'm making a small neck, and I'm using a varus needle. Varus needle, as usual, the same teaching. See my little finger resting on the abdominal wall here. If you suspect cirrhosis liver, and for example, small things there. If you cirrhosis liver like the suspected case, don't go this area because there will falcium ligament vessels may be there in case portal hypertension. But this scan wise not there. So those cases you can go like left side. So avoiding this falcium ligament, if you go, then the problem will not be there. Now I am connecting to insufflation. The basic test you all know. That is, I don't think you need to repeat it. See, it is fluid going well. Now I am connecting to insufflation. The pressure I am keeping it 14. And now see, it is flow okay, fine. Always try to lift the abdomen for a short while till the new imperitoneum. Otherwise, the tip of the needle touching it, then you might think bowel or momentum or gas may not go. See, now we can appreciate. And 5 cc gas enough. Percussion fired out. But in this case, acute gallbladder, you may not have a space. Percussion here is no meaning. Percussion over somewhere, look at the flank fullness, that is more important. Anything wanted to ask? Now go ahead with the discussion that regarding the port placement. I will be happy about it. Standard minimum 4 port. In addition to this, I will be showing inside. In additionally, we made an additional trocar depending on the finding inside that I will be telling later.
So when the maestro plays, then everybody simply just listens.
Good afternoon, sir.
Good afternoon. Good afternoon. Yeah.
First, so happy to see you're operating. My
These
teacher,
people don't give me gallbladder today. That's why I come at least to take our gallbladder, do it. But I have to recollect what I was talking those days, basic things. And I'll try my best. And you make me to talk more by asking questions.
Yes, sir. What you have told, like there's no iota of doubt. Everything you have cleared in 2 minutes. So, but one small question, sir. When do you plan for an epigastric port? The initial port.
Initial epigas port I don't go, and if at all I will go on the left side of the midline. I will choose here to go here. I may use for a momentum or transverse colon tracking down. Epigastrium is little. Now the pressure has reached 12 and abdomen distension is adequate enough. But if you think abdomen is loose in the ladies, multiparous or hanging abdomen, that case keep pressure raised. You can keep up to 20. Then the muscle will be tight. Then you can make it a easy trocar. Many people holding the abdomen, fat and skin will come, abdominal wall will not. So the trocar injury can happen during the insertion. Now it is fine. Now I'm making a 10 mm, enlarging this. Holding 10 mm. We pray there should not be cirrhosis. And 5 seconds keeping inside. Yeah. Saline. Now the most important is to get the gallbladder more prominent. Okay, sister, head up. See, as we raising head, the great momentum falling down. This is colon, bowel distended with the gas, and there is no variational injury here. It's fine. Now, right side we'll try to raise up. This type, okay, this is a lateral right. Yeah, okay. Now I'm putting my finger like here, you can appreciate. Is it marking which are done correctly or not? Yeah, exactly. Slightly down. This is 10 mm. And initially the teaching was 5 centimeter from zip-out process. Many surgeons used to put in get 5 centimeter. The liver will be lowered down, particularly female, visceraptosis. and they used to struggle. I'm inserting the trocar in the midline, going to the right side of the falcium ligament. So during our dissection, falcium ligament will not come in our way. Now we look at reducer, grasper. Gallbladder distended, but not much of acute. Probably clinically initially would have come. So now see, I'm putting my mid-clavicular. This is leverage. I should come down slightly. So this is where it is good angle. Okay. Should not make it here above. You have to work downwards. That is difficult. Now 5 mm. So then I'm making a working trocar. See, I'm going very laterally. The marking which was not appropriate. Okay. Now, this type of gallbladder which is distended, better to decompress. I'll show how we decompress it. Holding puduma. This is it is because infection. It is not a development adhesions. Okay, fine. So I want to decompress it. Here I introduce a trocar into the gallbladder, taking it out. There is a needles, especially for this purpose. I'll find out the trocar which is a good location. எடுத்துருமா எனக்கு கையில் இது கொடு, கிராஸ்பர் கொடுத்து, கிராஸ்பர் கொடு. ஏமா சக் பண்ணாதீங்கம்மா, நான் காமிக்கணும். அதுக்குள்ளே எடுத்துட்டீங்க, உள்ளே வச்சிரு, க்ளோஸ் பண்ணி வச்சிரு. சக்ஷன் reduced section உள்ள தள்ளுங்கம்மா. Okay, see, decompress here. In this case, what you do, if it is infected bile, you can take it out, put it a saline few cc's and suck it out. புடுமா எடுத்துட்டு section irrigate பண்ணுங்க. இதுக்குள்ள இல்ல irrigation ஆன் பண்ணாதீங்க, இது கழட்டி syringe போடுங்க. If you connect to irrigation, the pressure suddenly mounts, the stone can slip into CBD. அதுலயே போடுவீங்க, சைடுல போட வேண்டியதுதானே. சரி போடுங்க. இன்ஜெக்ட் போடுமா, எங்க மாத்தி போடுறீங்க. அதில் போடு, இதில் போட்டு எடுத்து போடு. இன்னொரு சிரிஞ்சு போடுங்க. போடு. Okay, see, I distended. Now suck, open, section. Okay. So once or twice you can do, so that infected fluid, if it is there, it will suck. வேற பவுல் கிராஸ்பர் இதில் போடு, இதில் பிடிச்சிங்க. கிராஸ்பர் அந்த பக்கம் போகணும் பார், மாற்றி கொடுத்து இந்த பக்கம் ரைட்டில் கிராஸ்பர் கொடுப்பீங்க. அதில் போடுமா எடுத்து. Okay. Now what you do, put it at the 2-1. You can see the stone debris here. Adil central. Okay. Okay. So you can same hole can be closed, and then don't push too much. Holding good in the book. Code. Holding put. Now the trocar is there is a debris like I will take it out. Wash பண்ணி கொடு. Small, very multiple stones there. It went into the stone. It's actually.
Sir, while irrigating,
yeah,
What precautions should we take so that it is not dislodged into the CBD?
Not to, that's why not to inject too much, and just
Yes.
a few cc's of saline enough. Don't use suction irrigation. It may suddenly mount to the pressure. Stone
Okay.
volume.
So
That's why just
irrigation has to be very gentle.
not irrigation. We call syringe.
Syringe.
Put
Syringe
flea in
again.
there.
Right.
Holding put here. See, now look at here. This is hilum. This is a duodenum. Duodenum stuck here, and here also the momentum. See, just flimsy. But this is development addition. It's up to this infected. Suppose if you don't get adequate dissection here, if it is too much of inflammation, one can put a here. There's a between the mid clavicular and here 5 mm trocar. You can lift the quadrate lobe. It is called the quadrate lobe lifting technique, otherwise called French technique. And one more trocar, you can have the left side. So here, we can put it here so that great transverse colon great momentum can be retracted down if necessary. These two additional trocars if necessary. This type of difficult, then you can use some energy source. Otherwise, you can try with always gallbladder goes with the artery. Now, connect.
Sorry.
See, this is a duodenum. Very careful. Change my grasper left hand. See, this is it is not just recent infection. It is because of previous developmental additions. That means we have to carefully take it down this fat. Not cut it toward duodenum side. You can even open gallbladder, no harm, but you should not injure duodenum at any cost. Close up. See, the plane is very important. Here, not go to this side. We can keep it little more this side, like. If you have energy, harmonic scalpel can be used. Suction. A suction tip can be used like a blunt tip, finger like dissection, once the peritoneum is incised. And this using it, suction come. Suck. Suck. See here, you can appreciate duodenum is there. Very careful. Camera in the correct. Curved. I think must be some a long time back addition. There are vessels also there. It is not. The camera close view is very important. You can appreciate the duodenal wall here. That's why the clarity very important. Picture. Camera in the pocket. Keep the plane very careful. This plane should not miss. This is infundibulum. Blunt dissection, no sharp here. Sharp means scissor, you can use cutting it here. That is. Artery this side. Suction. No, straight away, no, callet triangle dissection not possible. We have to keep it suction. Gas piece, this particular case, you can keep a gas piece, keep the plane dry. See, this is a plane, very. And this is peritoneum, this is duodenum. That's why I'm holding the peritoneum leaf.
Sir, Manoj here.
Yeah, please.
Sir, if this duodenum is not peeling off,
Yeah.
what will you do, sir?
I will take it a small serosal cut like here, not open fully. I will take this layer with the duodenum, one technique.
Okay.
Suppose if it is not possible there, I will cut the infundibulum here, very as distal possible. Then finally, I will inside, I will core out the mucosa. That I will be showing some videos.
Okay, sir.
Covered. See, this is a peritoneum. The duodenum has come down here. Artery.
Sir, good afternoon. Sandeep here, sir.
Yes, and yeah.
Sir, in this particular case, if we would have encountered liver cirrhosis,
Yeah.
how we would have differed in the surgical plan, sir?
Yeah, here I will be going same, but here I will not go to the liver side. I will try, depending on the cirrhosis nature, I will modify it to subtotal, leaving the bed, but taking only the mucosa. But if a portal cavernoma here, then there is different. Then I will not go to the hilum at all. I will divide and the suture come back.
Sir.
Now you can see it is getting separated.
Yeah, very well seen, sir.
Okay. Hey, camera in the book got need to push the okay. So now I will be showing the Callet's triangle dissection. So I will use the section. So posterior I have done enough. Sulcus we could not see. Sulcus will be low down. These are all recent an addition. Hook. Now anterior dissection of the anterior peritoneum. I'll take it. Generally, what I'll do, and here I'll be taking the peritoneum here and posterior. Posterior already been done here because separation. Here we look at generally pedicle. Don't go here. This closer to this is a danger zone. We consider infundibulum and a safe zone. See here.
Okay.
Say I'm taking the only peritoneum. Nothing inside. I will go. If you can, who can use a hook at me? Who can hook peritoneum adhesion? Then the calyx angle dissected. See, this is a peritoneum. I can hook. No vessel will be here. Okay. Suction. The gallbladder is a lateral placed gallbladder. That's why it is. We are not able to get it anterior much. Suction. Careful. Blunt dissection. This is pedicle. There may be vessels we don't know. Posterior. Okay, come back. Now anterior. But I do like this. This is a name by Bercy. It is called flag technique. Flag like this, anterior, posterior. Now cystic duct and pedicle looks like together. Light. Okay. Come this side. See, and I'm just to go blunt dissection here. This is where the hook dangerous. This instrument is a good instrument. I'm not using artery. Even a slight oozing is there. We can wait, but don't use energy in between. We don't know what it is going to be inside. And this is a place where sometimes you have to expect stone. A cystic duct stone, there can be reason for this distended gallbladder. We don't know. Suction. So I'm making the dissection between the pedicle and this, the calyx little widening. Suck. No energy source, no cutting any tissue. Suck. Now I go on other side. Now you can appreciate here. After this, once identify, then you can put a clips, anything later, fine. And the holding Kuduma. You can see arteries in the front.
Okay.
Bipolar. If you have bipolar, you can use a dissection, what we call the calyx triangle, cystic and hepatocystic triangle formation, and this can be extended here. Since we don't know anything here, not to, unless you see, this is bipolar is a good one to look at. This still we don't know here. Okay. Suction. It looks like some stone in the cystic duct. Now, I think ICG on, please. We are already given 2 hours before ICG. Suck. Now you can see this is a hepatocystic triangle. It can be widely done here. Too much bleeding, that is a problem. I'm not doing it more. So here nothing is there. Now we don't want to go. இது பிடிச்சிக்குமா சிஸ்டர் ஐசிஜி ஆன் பண்ணுங்க. சேம் லென்ஸ் ஒன்லினா எப்போ கொடுத்த எவ்வளோ நேரம் ஆச்சு? சக் க்ளோஸ். This is CBD. Fat is over the CBD. Sir. And nothing is seen there. Bile duct here. Even bile duct also not visualized. Probably secreted or I don't know. But liver is seen. Kaudu kuduma. Pudi made. But ICG is there or not? The question was asked. Somebody, facility is not there. How to do? Anatomy differentiation is the one that very important. Bipolar. And keep gas piece all the time there inside. Suddenly bleeds. One can put a hook. I'm extend the hepatocystic triangle a little wider, but generally they say 1/3 of the gallbladder bed. That is too much, but you should clinically identify this is a normal gallbladder side, this is a liver, this pedicle. If you think it is okay, fine. Too much when you do, then we'll be losing the. Now here when a bile color comes. My instrument is getting color. Okay, suction. Now I am going to dissect the cystic pedicle. Light in the light. Yeah, suck. I am keeping instrument here just for retraction. You can appreciate here, and here I don't want to go more. There, this is CBD. This one. Now at the closer to gallbladder, I can put my instrument like this. Now I am going to dissect artery and the suck. Code.
Sir, Manoj sir.
Yes. Yeah.
Sir, if you think that there is a stone in the cystic duct, in this point, how does the dissection differs?
That's why I should not dissect too much. I identify the cystic artery. See here, this is cystic artery like here.
Okay.
And if I separate it, put a clip, and then I can open the cystic duct.
So cystic
See,
duct
you can appreciate here.
Yes,
Yeah. I can't explore cystic duct keeping a artery. This.
Oh, sir.
Once taken, then we'll be knowing cystic duct. It is a simple cystic or a stone. Now you can appreciate. And
yes,
only thing you have to, it is not going into the liver side. Now we are sure. Now we'll put a clip. Not to go too much of dissection, get into avulsion of artery or this. Generally teaching 3 artery better, but if you have harmonics, anybody using it energy, distally is no need to worry about. But clip is there, don't use any energy source. See, sir? Now I'm dividing the cystic artery. Are you able to identify now? Section?
Very well seen now.
Yeah, now I can go open partially the cystic duct. Before that large clip everything, what we call sentinel clip to the gallbladder side. Suck.
Sir, Jugindra here.
Yeah,
sir.
yeah. Kaudu Kuduma.
Sir, in the event that the separation of artery and vein is not, artery and duct is not possible.
Artery?
Artery and duct, if it is a cystic duct, is the separation is not possible.
Kuduma, large.
How is it advisable to keep the two together? Is it advisable?
Generally, it is not advisable, and but at that time too difficult. Then you go to cystic duct neck, infertile cystic duct neck, and this. If a stone is there, then it is get with differently. If a no stone, this is a sentinel, scissor. So anything from the gallbladder side will not spill out this side. So now what I'll do, I am partially open this. Suction. Suck. See, this is where doubt to know. If a bile comes to me, I am happy. I will milk from the CB side towards the gallbladder. Like here.
Free flow is there means you will leave it alone.
Say, you are able to appreciate debris coming?
Yes, sir.
So you can see this debris. Now stone is coming.
Oh.
So what we suspected it is happened. Stone falling forceps. ஹீமோல கிளிப் வச்சிருக்கீங்களா? Code. No, still some more may be there, and we don't expect all the time bile coming. That edema, this may not be there. Okay. This is suspected site. Okay. 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 Irrigation. Now I'll irrigate the debris, small debris, take it out, then clip. Here, again, controversy will be there. What clip is ideal? Clipping, looping, or suturing? Irrigation. Suck. In this particular case, everything is possible. You can do it. Irrigation.
Sir, what exactly made you suspect that there is content in the cystic duct? Could you palpate it, or is it your experience?
Experience plus feel also. They feel same thing. In fact, you also will be there. That is fine, but it is intuition.
Right.
Sometimes experience will.
Experience.
Right.
So now this is, I'll show one clip. Use a hemolog. It will not crush that cystic duct. Agreed. If you use a titanium clip, at the titanium. If you use a titanium clip, it may cut through sometimes because of inflammation. Agreed? Now I am putting it as safety. This. And people used to say hemo clip may slip. but it is not. We have been seeing it, scissor. It will not slip. Proper apply, it is the best way of doing it. Okay.
Yeah.
Suction. This ICG didn't help me, this particular case.
Is this a stored system or
This is a striker.
striker?
It's a good, but the timing, all also is there. Now you see that some bleed there. Bipolar. Come back, come back. Suck. Curved எடுத்துக்குமா curved கொடுங்க. I'll use a bipolar now itself hemostasis, and once you separated, we don't have that control. And never try to hold the tissues. It is because thick inflammatory. Bipolar. Still, that hepatic artery may be going there or not, but still we are safer. We are on the towards the gallbladder side. Holding grasper, bowel forceps. Plus hook. I'll use a hook monopolar, then I may change it to bipolar coagulation in the surface if it bleeds. And this hook can be used to tip as a hook, but the base if you use it like a spatula. Change பண்ணுங்கம்மா, ICG change பண்ணுங்க. Yeah. Push the tissues. This is where that cirrhosis liver or not, must be very careful not to go. This one. So this is medial twist for lateral taking up. Medial twist for lateral one.
So Manoj sir, sir, if it is bit of intrahepatic gallbladder, how does it differ?
Intrahepatic completely or partly?
Partially, sir.
Then we have to split the liver at that. No, usually it is very thin film or liver will be there. You can split the liver, then it go inside. அம்மா குயிலமாம்மா நீ மேலே தள்ளுற. Pardon? Fundus technique when you are not able to retract liver, and then you have to use. Okay, clean lens, clean. Now, when we're separating here, you have to see the tissues here. Don't go to the parenchyma. That is a more important thing. And killer. As we release, always the retraction should be slowly, it should come down. Hooked. Now I will do medial separation from the liver, then it will come. Even it, partly that quadrate lobe is hiding the edge of the liver. See, look at this one.
Yes.
Now, using a spatula type, but liver, this is a liver tissue is coming here. So clean the tip. If you have a spatula, that can be used. That flat blade is a better thing. Now, so look at here. See, this is a plane, correct plane. This is more deeper. Now I will use a spatula, go to that. Suppose if you open this gallbladder, don't nothing worry. Only problem is stone spillage. Keep a bag ready, put it inside. I think gallbladder is getting open. You can appreciate that gallbladder is getting open is not a problem. I don't want to get the liver more than section.
Highly inflamed and fibrosed.
Yeah, suck. Small stone. Suck. Bipolar. Kuruma. And the mucosa and the wall there is no space. Generally, we can strip of the mucosa leaving the wall. Generally, I will go like here. This case, it is not. See, it is full gallbladder wall is coming. இந்த பக்கம் பேக் எடுத்துக்குமா?
Sir, in a similar case like this,
Leave it.
where it is
Yes.
very difficult to remove the wall of gallbladder, can we leave behind some wall attached to the liver?
Yeah, positive wall of the gallbladder, you can leave it. Mucosa, you can fulgurate or remove the mucosa only.
Sir.
And if it is not coming, you can fulgurate with the artery. It is enough.
Yes, sir.
But this is a corrective one. And I removed part of cystic plate has come. It, that is somewhere bleeding may be a nuisance.
Sir.
Closer, closer. It usually stops by itself. Okay.
So you have demonstrated very nicely that opening of the gallbladder is safer than going.
Yeah,
deeper.
100%. I have opening gallbladder makes you more comfort. This guy, otherwise, gallbladder can hold it.
Right. Beginners, when they are starting, they feel that if the gallbladder is open, then that surgery is not good. But you have demonstrated exactly that
Correct.
when
Yes.
it is required, that is much safer. So we should not be too much worried about opening up the
Yeah,
gallbladder.
no. As long as you don't leave the infected bile,
Yes.
frequently you suck it out, no infection.
Right.
That's why irrigation is very important to do in hook. Now almost separated, high-most is checked, then I'm going finally.
Right.
Bag. Let me put it in the bag before checking the hilum.
Sir, Manoj,
Yes.
sir. Sir, in these kind of cases, two things. Sir, how will we avoid that venous injury from the gallbladder bed?
The bed, you mean?
Gallbladder bed, sir.
Yeah, we'll be stripping this, vein will not come.
Yes, sir.
Generally, vein is not superficial. Very rarely, serosilivar bile will be there, bile duct. That is a problem. And keep on closer. There may be some oozing from the liver, but it's fine. Rather than you want to hemostasis too much, then one of the vein will get injured. And many cases you can identify with good vision. And either above and below you can put a clip. Otherwise, you can take a stitch. No other way, no. We have done few cases like this. We'll be doing it. And bipolar vessel sealant you have, you can use it.
Yes.
Bipolar vessel, this is bipolar. It is not a good for now. You can see it is not that powerful. Vessel sealant is there. That is like a ligation. It is a very, very good. Here, if you keep it like this, immediately it will seal nicely. This oozing we will leave it another 5 minutes, it will not be there. But still, anyway, we have to keep a drain at the end.
Sir, for beginners, what you would suggest should be the indication for drain placement in a gallbladder surgery?
Drain this, but this case myself, I'll also, whether junior or senior, very important drainage.
Sir.
And because that bile is not going to be there, I'm sure, but there's
Sir.
some amount of collector that it will be irrigant, shoulder pain, and nagging type of pain shape they will have. Better to always take it out. So
Yes,
I'm
sir.
bringing the bag outside. I'm dilating this wound slightly more. See, you can Kelly clamp is going inside and dilating it. If necessary, very thick ball gallbladder, then we have to make a small incision, little bigger also. And anyway, we can. That is more important. Now I'm introducing here. You can see this is a sponge holding forceps, and you should avoid a breach. You can use Alice also. This one tip must be very thick. I may even take an incision also slightly.
Sir.
Knife. Camera outside. Light off பண்ணிருங்கம்மா. Alice. இது மறைக்காது. One more, Alice. I'm holding the pendulum here, and like it is not coming, you can cut also. I'm right side இறக்கிருங்கம்மா. கேமரா தெரியுதுங்க. சிசர் அந்த பக்கம் இருக்குங்க. கீழே டேபிள் டவுன் பண்ணு. ஸ்பஞ்ச் ஹோல்டிங் again. சிசர் அங்க பண்றது இப்படி அவங்க கேமராவுக்கு அந்த பக்கம் தான் வரும். Actually, it is a piecemeal, but anyway, I don't want to spill any stones inside.
Yes, sir.
Still, it is not coming. இது பிடிக்க பண்ணிடுமா.
Quite thick wall, sir.
Sister.
Sir, there are two questions.
Yeah, go ahead. Yeah.
Sir, should all gallbladders be removed in a bag?
Yes, open gallbladder, yes, and polyps, yes, infected gallbladder, yes, and thick wall gallbladder, particularly, you put a bag, you can. You see, now I am able to do it piecemeal now. If without bag, not possible. Then unnecessary wound, infection wound. Hey,
So the
sponge
next
only,
question.
sponge only. Yeah.
Next question. The choice of removal of the specimen, the epigastric or the umbilical port. Some are proponent of umbilical port for removal, saying that the scar is better there. What is your opinion, sir?
That is Western technique is umbilicus.
Yes.
Indians, I don't know, and I felt that the epigastrium is a section. It's a better way. I started this. The people trained the beginning were trying umbilicus slowly. Now, umbilicus do people still, but very few. Epigastric becomes standard. Western people don't do epigastric.
Yes. We also feel that if there is any spillage, it is better to have it in the epigastrium rather than the umbilical port.
Another thing,
yes,
people think it is extension, difficult, bleeding more. Never happen. I have not done any umbilicus unless there is some problem there, no? And later, slowly, the people who are doing umbilicus also change it now. And second thing, when they asked, I commented, this area in ladies it is covered, no? Male, upper. Jacket all coming. Umbilicus exposed, no? Yes. So Indian beauty lies umbilicus. I don't want to spoil that. Irrigation. Right. Yeah. Now, before irrigation, sister has given me wound port closure. I'll put it this, then I'll reduce the trocar. Hold this. Put him. And slowly I learn, and not only here, even appendix or any surgery you do, try to avoid umbilicus. Not only that, Indian people not experience much cleaning the umbilicus. The dirt collects there, it becomes a problem for them. They are afraid to put a finger inside cleaning it. And that way, I think it's better to, very outside umbilicus is better. Irrigation. So I will check the hemostasis of the irrigation, then I will put a drain, subhepatic, not diaphragmatic. Still some people say, here putting it diaphragmatic. No? Collection is, has to go from here. And always doubtful is there, look at the appendix, and if it is appendix is a turgid or some reason there, then you can combine, same 1 extra 5 mm. The suction stone got blocked the suction drain. Your point of spillage of bile and epigastrium, yes, that's why I made head down and right side down. Irrigate, it goes to the over the liver, spills out. We can irrigate, take it out. That's why infection is not a problem in our. Not only that, umbilicus by chance spillage of stones in the small bowel, you cannot pick up.
Very true.
Then that's some or other started. I felt very happy. Then subsequently, I changed everybody there. Because I was trained by Eddie Reddick. I don't know how many of you remember that guy. Anybody knows Eddie Reddick?
No, sir.
Eddie Reddick is a guy, the 4-port technique is his name only. He only described this. And lucky I was there, Gallbladder, I saw, I got training by him. And European is, most of them, Kusheri and everybody, they follow French technique. That is quadrate lobe, and they stand between the leg doing it. To my knowledge, only one surgeon, now I used to say, Professor Udwade was doing it the same, because he was trained by Dubois, French surgeon. He continued till us. Irrigation, most important irrigation. Even no spillage bile, irrigate. I found shoulder pain is less by irrigating. No scientifically proved. Probably dissolved carbon dioxide may be returned to the diaphragm. Thorough irrigation, that is removed.
Sir, these kind of difficult cases, no? How do we find out whether there is any loshka accessory bile that running through the bed? So
yeah, accessory very rarely come. And initially, I had one of the patient. I did acute gallbladder so well, cystic that clipped and everything. Next day, I saw bile coming, not through the tube, outside the tube. Then I got panic. Through the tube, I would have waited. And then I put a scope next day. I saw bile trickling from the bed and sutured. That the patient went home. Yeah.
okay.
So epigastric trocar also we close it. We introduce a camera through epigastrium. இப்படி தொடங்கலாமா இங்க சலைன்ல கொடு சுவிட்ச் இருக்கு. ரெகுலர் ட்ரெயின் கொடுத்துட்டு போதும். ஓகே போதும். So this is a camera port. Hey. Good. Okay. Trocar. Hey, camera put. Now I'll put a drain through the lateral most trocar 5 mm. Clean pani. And the drain is any size 16 plus is better in this type of cases. And otherwise, normally right tube size is okay, 12 size. And 16 size goes to this 5 mm trocar easily. This is 20 size. Okay, thank you. Close பண்ணிட்டு dermo பண்ணு.
Very difficult surgery, sir.
Thank you.
It was a pleasure to watch.
Thank you. Any doubt they can we'll discuss. The other case ready. They are going with another case. Nalangale porapla.
Yes, sir.
Yare? Anand. Okay. The another case Anand Vijay is starting.
Sir.
Yes, sir.
Parsari.
Sir, it was real pleasure to watch you live at the comfort of our places. Really thankful, sir.
Thank you, sir. It was great demonstration. It's a long time. Yeah.
So in the meantime, the AV technician has to shift the camera and the system and all to the next OT. We'll be proceeding with the second case. So this is an 56 years female patient who came with abdomen pain for past 2 days. She was already a known case of gallstone disease for past 3 months. She was diagnosed 3 months ago, but she didn't undergo any treatment. Now she came with acute pain yesterday. Her investigation was almost normal. ultrasound showed multiple ultrasound showed multiple calculi with distended gallbladder, and there was thick-walled GB. Sir has already put port inside the patient. We'll be proceeding with the surgery. In the meantime, if any doubts is there, moderators can talk among themselves and clear, and Chief will be joining us in a moment. நீங்க பேசிக்கலாம் சார். அடுத்த கேஸ் பிரசன்ட் பண்ணிட்டேன் சார். அவங்க ஷிஃப்ட் பண்றதுக்குள்ள நீங்க
Hello.
Sir,
Yes, sir, we are there.
Hi. How are
Hello,
you?
sir.
I'm fine, sir. Very happy, sir.
I know seeing all faces. I'm very delighted.
Very happy, sir.
Parser is getting ready, and we can start. Meanwhile, any questions there in the box, you can raise them.
Sir, if there are no much questions in the box, but if the stone is stuck in the cystic duct and you have
Yeah.
already divided it, so how will we go about it? Like, how can, if we are not able to remove
Yeah,
it?
don't cut the cystic duct fully. Partial cut and then milk out. Then you can go. In case you have cut, then it is carefully you have to work out to take it out the stone out, milking it out, and then with the left hand grasper, small instrument, hold the divided end of the cystic duct. If you have a sufficient length, you can put a loop or clip. Suppose less than 5 millimeter, then you can't do anything, it will not safe. Then suturing is the best way to do it at that level, after stone extraction. And a thick cystic duct also, and clip is not ideal. If at all use clip, use a Hemolock first clip. Then it will not crush. Jogendra, the
Yes,
man who behind this lap step coli throughout India, the man who is popularizing it,
Thank
very
you, sir.
happy. Jogendra, your comment now. The question will come to you.
Only
can
comments,
talk
sir.
about
We are enjoying the master just playing very beautiful symphony, and we are just simply sitting and enjoying.
True that.
Right.
So, Gallbladder not forgotten.
Yes. No, sir.
Never, never.
You are the master, and you are still teaching, sir. We learned so many things.
Thank you. And Jogendra, you can talk about the safe lab coli, the broad concept before Parsadi. How you have done? How much relevant today? Your perspective. You have been going throughout India, conducting courses through Amasi.
Yes, sir.
The safe lab coli has become so successful that way, making one of the commonest surgery is a gallbladder. That safe lab coli is more important. You briefly comment, and Sandeep is there, Sabnesh and Manoj, all
Sure.
of them can talk.
Yes, sir. Thank you, sir, for that opportunity. First of all, I must pay my gratitude to Palnivelu sir himself for originating this idea of doing some program on safe laparoscopic cholecystectomy, which we all felt that because it is the commonest surgery worldwide, and the number of surgeries done at very many small centers is very high, so we should do something to make it very safe. And it was in 2018 that sir, during a executive committee meeting, proposed this program to do some program on doing safe laparoscopic cholecystectomy program for the country. So from then we started, and then I started collecting data from the very senior surgeons who are doing cholecystectomy across the country, all Amasi members and very senior surgeons who have done, some of them have done more than 20,000 laparoscopic cholecystectomies. So 110 of them were questioned about their experiences and their thoughts on about 250 questions which I sent them, and got their reply. And after that, what we have done is designed a safe lab coli 1 day full day program, which is a participatory program where there are no lectures. It is all on the same questions that I had asked these experts, and also video based. So all on the videos, questions were asked, and the audience were asked to give answers as to what they would do if they were in that particular situation. So this is a one-day program, full one-day program, and all so many aspects of laparoscopic cholecystectomy over there. And this has been started first in 2019, early 2019 in Kolkata was the first event that we had. Then later on, we have now done it in all the major metros of the country, and other smaller cities. One very important one was in AFMC Pune, which was the first program that we did for the armed forces for laparoscopic cholecystectomy. And then now we are going to do it in Tezpur. Tezpur on 30th of this month, we have the Safe Lab Chole program in Assam, in Tezpur. So that is how we are going, and we are taking it to now smaller cities across the country, and also tying up with the ASI so that it can be done in more cities and in multiple cities together, so that many people are exposed to the ideas and thoughts right from Palnivelu sir and all the other experts in this laparoscopic cholecystectomy. And we have taken this to other countries nearby as well. So we have this Sri Lanka, Nepal, and even in Myanmar, we have done a workshop there and demonstrated these surgeries. So that is how we are moving ahead, sir.
Yeah, very nice, Yundra. You have broadly
Thank you, sir.
brought out today. I think Parsar is starting now.
Right, sir.
And during the time, all same thing also you can discuss anything. Different perspectives, very important to know. And you know, Parsar is a senior most surgeon here with me, and done a lot of work in minimal access. And I hope a lot of doubts going to be there that he will clear now in his life. We'll start that. And
Yes,
we
sir.
have 2 more cases also. Time permits, we'll be taking up that one. Yeah.
Yes. Sure, sir. Thank you, sir.
Parsardi? Yeah.
Good afternoon, sir.
Yeah, am I audible?
Yes,
sir.
yes,
Very
sir.
good.
Good afternoon, and
Very good
nice
afternoon.
to see you.
Okay.
Thank you.
Good afternoon. And so today we are planning for actually 3 cases. So this is going to be second one, and next one is ready. As soon as this over, we'll go for another case. And this is the history. I think you must be heard the history section.
Yes, yes, we got the history.
Yeah. So any case, any gallbladder, if a patient had a pain, and all of you know about this guidelines, TG18, no, Tokyo guidelines 18, second guidelines. So it is a mild, moderate, and severe. The patient has only pain, that is called grade 1. There is no other dysfunction, organ dysfunction. And if it is a counts is more than 18,000, and then wall edema is there, and then mass in the right upper quadrant, then it is called grade 2. And then it is associated with the organ dysfunction like liver LFT deranged, LFT, and renal function is altered. Then it is called grade 3 acute cholecystitis. And most of the time what we are getting is grade 2, and then sometimes we are getting a grade 2. And before going for this live, and if it is a grade 3, suppose you are getting a patient with organ dysfunction, you have to see cardiovascular, respiratory, renal, and the hepatic. If these 4 organ dysfunction, and it is most of the time it is reversible after surgery, you can take up the patient for surgery. That is all cardiovascular, hepatic, and kidney is called, renal is called the positive predictive factor. So even if it is altered, this function is there, you can go ahead with surgery. If the patient had a respiratory function, respiratory dysfunction, and neurology, neuro dysfunction, some delirium or some level of some unconsciousness, dizziness is there, then that is comes under negative predictive factor. So if it is a negative predictive factor, lab chole will not benefit to the patients. Then we can go for some other endoscopic method, percutaneous or another thing, and then we can treat the patient with the other factors. So this is the preoperative evaluation of Tokyo guidelines with the positive and negative predictive factor. So with this, I'm going for this one. This patient is again 3 days old history, and you can see all this momentum is covering like this. And when the momentum is covering like this, everybody's intention is go and separate the momentum in the fundus. So that should not be done. Sometimes if it is adherent means you will go in a different plane. You will go through the momentum or go through the gallbladder. Always if the momentum is adherent here, you try to come to the quadrate lobe. So this is the quadrate lobe, and then separate the momentum from the quadrate lobe, and then go to the medial side, lateral side, and then separate the momentum. So this is the way we have to separate the momentum. And this looks around 2 days old history. You can see the lot of edema here, in gallbladder wall edema also there. And some of the, maybe it may go for a gangrene if you leave it for a day. And if a gangrene means the cystic artery get involved by the edema, so it will go for a gangrene. And always when your momentum can be separated with the suction nozzle. It is like our finger, and you can introduce and then you can separate the momentum. So like this. And when you are separating the gallbladder, you can see I am just holding the gallbladder like this, pushing it like this. Suck, suck. So how much pressure you can give, it will come with the practice. And you can, tissue should not get injured, but same time we have to get adequate exposure. So that much amount of traction you can able to give. And this can be excised, released with a harmonic scalpel or any other device. And I'm releasing this before decompression, then I go for a decompression. And chief doesn't use energy device for lap chole. It's actually doesn't require. But if it is available, then you can use it for a acute condition. So always give traction and then see the lower blade of the gallbladder, the harmonic scalpel. It should not injure the vital structure. The disadvantage of harmonic scalpel is a lot of fumes will be there, particularly if you are using to the edematous tissue. Okay, so it is released, and I'm going for a decompression. I already is described. Ball holding. Ball holding. So now you can see in the external view, and now you can see this laparoscopic view also. You can see this obturator is coming from the 5 mm trocar. It is in the subcostal level. So what I do, I just take this trocar, and then I am trying for a puncture. So now I press the gallbladder with the trocar only, not with the cannula only, not the trocar. Obturator is I pulled out. So now I support the gallbladder. I'm not able to hold it. I just supporting it like this. Now I'm pressing it. I puncture the gallbladder. So now, syringe, so now you can see this trocar first. Can you camera lap clean mini camera. So it should be done. Suppose why I'm showing this one is pad. So now pad. So now you can see I'm taking it for culture. Suppose if you are operating for an empime or anything, you can take it for culture. Close suction ulla podupo. So just I want to show this. It is very easy way. Instead of taking it through the suction nozzle for a culture, you can take it through the side nozzle of the trocar. So now I am decompressing it. Can you see this? It is getting decompressed.
Yes.
Is it clear?
Yes.
Yeah. Okay.
Yes.
Very
So
clear.
when you are
Very clear.
taking out this infected fluid, it's like a mucosal gallbladder, and suction on. Don't close the suction on. Suction on. So with the suction on, I'm taking out the trocar. Suction veliyilukada. I'm taking out the trocar. You can see trocar is coming out. Suction is on. Suction on பண்ணிட்டேரு. Take out. Suction வெளிய எடுப்பு. See, like this. So it is coming through the trocar. I want to show without anything. So the suction should be on all the time, so that the content will not coming out from the gallbladder. Okay. Pudichuka. Suction kudu. So this is the way of decompression without any fluid is coming out from the gallbladder. you can able to decompress it. Okay. So now,
Sir, you
and always try to start your dissection from the medial side. And suppose this duodenum is adherent, no, you're not able to separate, and you can do the type 1 modification. You can able to separate, most of the time it will come. And if it is a delayed case, no long duration or delayed case, then you can able to leave the duodenum, anterior wall of the gallbladder on the duodenum. And when you are retracting the gallbladder towards cranially, you have to see two things. One thing is the liver adhesions. Second thing is a falciform adhesion. No, falciform is sometimes it will adherent to this place, so it will be liver capsule will get there. So we have to release the falciform. If it is a liver adherence is there, you have to release the liver. Suck. So now I am going take the Maryland forceps with the monopolar cautery for the dissection. So always go close to the gallbladder.
Sir, you operate
So
all
if it is a vessel,
stages?
yes.
After how many days you prefer doing?
Yeah, that is a good question. And usually, according to the guidelines or textbook, you have to operate within 72 hours. Even the patient comes to you after 3 days, no, 72 hours you can operate. So that is the guideline says. But what is the gym practice? Patient comes on any day, even after a week also we can do surgery. But within 72 hours, a lot of adhesions will not be there. It will be easily separable. Can you see? It is easily separable. If it is a treated case, treated with outside for 4 days or 5 days, then patient reach you, then technically, no, the separation will be difficult. So that's why ideal is 72 hours. Acute coli, 72 hours you can operate. So my aim is to take out the duodenum down along with the adhesions. Along with the adhesions, I have to do it down. I'm not going here. I have to find out the infundibulum. I have to find out the infundibulum, and I have to lift the infundibulum. That is the first aim. So the infundibulum is the one. Only in a patient with the biliary pancreatitis patient, the infundibulum will not be there. And if you observe carefully, that gallbladder will straight away go and join to the CBD. That is a presentation in most of the biliary pancreatitis patient. But otherwise, the infundibulum must be there in all cases. Bowel holding suction. So if your infundibulum is coming out, that means posteriorly if you are clearing the taking out the infundibulum, then straight away you can reach the infundibulocystic junction, that is called safe zone. Infundibulocystic junction is called safe zone, and the CBD cystic junction is called danger zone. So just I want to go in a safe zone, so I am trying to take out the infundibulum. Suction is a very good instrument, and on and off you have to suck. You have to clear the field. Always the field should be clear, and for that you have to keep a suction. And if you have very much the distended or some post-pancreatitis head plugmon is there, your vision will be altered. Then you can press down here with the additional trocar, so that you can able to get a good view on the calyx. So here I can have a good, I'm having a good vision. I'm not putting any extra trocar. So on and off you have to clear the field with the suction, then you can continue the dissection. So gallbladder cannot be moved further, so that's why I'm holding the infundibulum, and I'm trying to get out all the structures from the infundibulum.
So in acute cholecystitis, you advise first to define the infundibulum, is it not?
Yes. define the infundibulum first. Most of the cases, you will able to get it, and you can do the total, you can do the total cholecystectomy if you are going to get the infundibulum. So now you can see that is the edge of the infundibulum here, and I'm going here. And if you go medially, you can see, previously there is no bleeding. Medially the bleeding, now the bleeding is coming because the vessel will be there medially always. So that's why I'm going laterally and then I'm getting the infundibulum. So the clear view, because of my little bit medial dissection, bipolar கொடுத்துரு ஒரு gas piece கொடுத்துரு உள்ள கொண்டு போற.
Is there any situation in which you need to do a laparoscopic cholecystostomy?
Laparoscopic cholecystostomy, no. Suction.
Somehow
No
we
need.
feel-
So because that's why I told, if you have a grade 3 acute cholecystitis, even if you see the patient in OPD or in ER, you have to, the surgeon should mention it's a grade 1, 2 or 3. If it is a grade 3, you have to look for an organ failure. So if it is a cardiovascular, it's a BP, hypotension, and then renal, some renal dysfunction and hepatic dysfunction, then you can take up the surgery. So that is called positive predictive factor, okay? And if you have respiratory, then patient required some kind of ventilation, and some neurological dysfunction if you see, then that is a negative. Then don't advise, even though if you're able to do surgery, don't do surgery because surgery will not benefit. Surgery, patient mortality rate is very high. So patient, everybody's think that because of the surgery, no complication happen. So that's why a negative predictive factor if you see, then you have to defer the surgery. You can go for a percutaneous aspiration, higher antibiotic, treated with higher antibiotic and other things. No need for laparoscopic decompression of gallbladder. We don't do.
Okay.
Can you see I'm going little bit posterior? I'm separating all the, because the infundibulum of the gallbladder is the one, it is lying on the right hepatic duct. That's why when you're doing a normal gallbladder, regular gallbladder without acute condition, we used to tell posterior dissection you have to do first. Because if you do posterior dissection, the infundibulum will come out from the right hepatic duct, so that you can able to, that one way it is safer, no? You will not, chance of getting injury to the right hepatic duct will not be there.
Yes.
So that's why we have to do posterior dissection first. These are all small branches, so it's no need for any energy device. Because of the edema, it looks big. See, that is a stone, eh?
Yes, sir.
So you are feeling the stone there, is it?
Yeah, I'm able to feel it. This is the stone. Can you see? Entire infundibulum is coming out now.
Yes.
Yeah.
Yes.
So Chief told about the flag technique. Flag
Yes.
anterior dissection, posterior dissection is possible only if your infundibulum is in your hand. Okay. So that is the first step in any acute cholecystitis, gangrene or any acute cholecystitis. Now I know cystic duct will be here because infundibulum is coming here, and this is the artery. Here, without dissection, I can tell artery is over the duct. Duct will go like this, artery will be like this. It is not two parallel structure. Okay. I think everybody can understand the anatomy, no?
Yes.
Now?
Yes.
Yes.
So
Yes.
after infundibulum is coming out, so anatomy is clear to everybody. So that's why that will be the first step in any acute cholecystitis. So now I have to dissect here. If I hold here, I may injure the vessel. Okay. So what I do, I go inside with the closed instrument, and then I just open the instrument. Okay. See, open, and then I retract. Can you see this? How much
Yes.
exposure?
Yes.
Yeah. This
Yes,
is
sir.
another way So in acute condition or any other condition, retraction of the gallbladder is no need to hold the gallbladder all the time. When you are doing esophagus, achalasia or fundoplication, we never hold the esophagus. We just retract the esophagus with the adjacent structure. That's why the same thing. You can see I'm just dissecting like this. Very good exposure. I'm not holding the gallbladder at all. But exposure is, even if you hold the gallbladder retract, this much exposure you cannot get. So now I dissected here. I'm suction couldn't see. Suck. Suck. Okay. So now I'm holding the infundibulum. Can you see this cystic duct here?
Now, yeah, now things are
Yeah,
clear.
it is very, yeah, okay. So now I'm going for a cystic artery. Hold, sister. I'm going for a cystic artery dissection. I'm going to clip the artery, then I go for a cystic duct. And safety triangle, a critical view of safety, that is the one I am look for here. Dissecting, I just looked it, nothing is there. And here, it is very well, it is going to gallbladder only. So I'm going to divide this artery after clipping. Suction kuduthittu kudu. Always you look for artery of Gallbladder, it will go from the cystic duct. Suction. And if you see, I will show it in external view. My inge kami in the epigastric trocar kami, right down money. Can you see this trocar? It is only 5 mm.
Yes.
Hello? Yeah, I'm not making a 10 mm. Anyway, I'm going to have a 10 mm. And if you have 10 mm, no, each and every time, little bit, shaky movement will be there when you are doing a Gallbladder dissection. Gallbladder dissection is the one, is prime importance in lap chole. So that's why, till I complete the Gallbladder dissection, I don't put my left hand as a 10 mm. So it will give a good control. 5 mm will give a good control. Whenever
Right
I
hand or
require
left
clip,
hand?
no, 5 mm, 5 mm.
Right hand or left hand?
Right hand, right hand.
Right.
Left hand is always 5 mm. Right
Yeah,
hand, usually we put 10 mm initially because we need a
Right.
clip and other thing. But I do only with the 5 mm because 5 mm means instrument control is so good compared with the 10 mm. 10 mm, some slight shake movement will be there.
At the tip,
And after,
it tends to wobble. Yes, correct.
yeah, because instrument
Very
size
nicely
is,
done.
trocar size is larger than the instrument size. So that's why still the Gallbladder dissection is over, I don't put a 10 mm trocar. So here, I'm going some more dissection before changing the trocar into 10 mm.
Do you do this for all laparoscopic cholecystic?
Almost all case, sir, all case. Whenever we are going for a clip, then we change to 10 mm. Otherwise, all lap chole will start with this 5 mm only, sir, because it will give a very good control.
Right. Point taken, yes.
Yes, sir. So all the level we are making this. This is the artery of Gallbladder. So I used to tell my PGs, Hutch, number Hutch, no? Like
Yes,
Hutch.
yes.
Sometimes the artery, most of the time artery will be here, duct will be here, it is like a Hutch. Now it is here, this side. So I'm going to divide this artery with the harmonic scalpel. Then only I can get the entire full access of the vision of the
cystic
duct.
duct.
Yeah, Pudichika sister. Now you can see how I am retracting the gallbladder. I'm not holding and then retracting the gallbladder. Just I am,
Spread demonstration.
yeah,
yes.
spread and then I push the gallbladder. So here and all in acute cholestasis, any gallbladder, no, the harmonic scalpel will be helpful. This type of small vessel dissection division can be done with the harmonic scalpel. Otherwise, I required clips or bipolar I can apply, but lateral spread is more than the harmonic. Suck. Suck. So now, these are all the small vessel covering the cystic duct. That also I am going to skeletonize before going for a clipping. Hey, Mathi, foot pedal. Can you see this? Another branch is going to the cystic duct
Right.
from the artery. It is the origin of the artery is going. And I'm not dissecting with the harmonic. The harmonic dissection is not advisable, and always do with monopolar. Then because harmonic, the lower blade will injure the deeper structure. So that's why any vessel, small vessel division, you can do it. Otherwise, dissection with the monopolar cautery is a better one for a safe dissection. I think it's very clear. The safety triangle also I can able to see it from here. That is a vessel.
The cystic artery seems to be quite large.
Okay, sir. It's normally it will be like this. It's not very much big. So I need some more posterior dissection to see the safety area. Always we learn from Chief Sir. We don't use this one hook in callets. Any gem doctors, they don't use because we feel this monopolar will give a better control than the hook. So a lot of small vessels are there. So I'm going to divide this, then I'm dissecting this. Can you see this liver surface here? Safety triangle of safety also is achieved. This is another small branch. So even in it's not possible in all cases. Safety triangle, critical view of safety is not possible in all cases, but as much as possible we try to make it. So can you see this? This any angle I can rotate and then I can take it small tissues. So the entire duct is getting skeletonized very nicely. And this looks artery. Whenever required, I can able to clip it also. I'm dividing this, then I'm going for a clipping. Since this liver surface is coming in the view, I'm taking this because lower, even though I'm not seeing the lower blade, and I'm very much, it is not touching anywhere because the liver surface is there. I'm not quite I can able to divide this vessel, small vessel, but I'm not doing it. Suction. Next case ready and suck. So all these things, callets dissection, everything is possible without any much bleeding. The only one step I can say is the release of mobilization of infundibulum is making all these things happen. Yeah. So that's the point I want to tell you further. So now I'm making my incision in the epigastric port to 10 millimeter. I'm taking the 10 mm trocar. So I'm going to put clip. It is a medium large clip. That is a medium large means it is a green color clip, 9 mm clip, basically 9 millimeter clip. So I'm putting only one clip, one more, and then I'm dividing with the harmonic scalpel. I'm not putting any clip on the specimen side. Even one clip is enough. You can divide with the harmonic. In acute situation, I'm putting one more to the cystic duct, cystic artery. Relax panni konja loose. 5 mm distance would be there when you are using a harmonic. So now I can have a better vision, and Maryland kudu. I'm trying to see the cystic duct CBD junction is not required. No, it should not be. Once you are having a adequate space to clipping, then you can clip the cystic duct. But just I'm seeing. And in our hospital, subtotal incident of subtotal cholecystectomy is getting very much reduced. because we are following all this technique. And some of the difficult cases, I'm using a laparoscopic ultrasound. For a gallbladder surgery, I'm using a laparoscopic ultrasound for some of the difficult cases. So I'm not going for a subtotal. Now it's very clear. So the CBD is here, must be here. This is the CBD. Only thing, this I can able to take it, but you can see a lot of small vessel I have to coagulate. Again, that will go to the CBD side. So I'm not doing this one. Okay. Is it okay, sir?
Yes, yes.
Yeah, I'm going to clip it. Just milk out.
Partha sir.
Maryland holding. Yes, sir. Yes, sir.
Partha sir, Manoj here. In what all cases you do lap ultrasound, sir?
Yeah, lap ultrasound. Suppose this patient, the stone is in the infundibulum. It is like a type 1 Mirici syndrome. Then, yeah, Mirici, then I can do lap ultrasound to see any CBD stone or left any CBD stone or not. That is the first thing. Second thing, if it is a very dense moss-like cystic, that is a frozen calyx. I'm not able to skeletonize the structure. Then I can open the infundibulum. Then I take out the stone. Then I do lap ultrasound to look for any stone left behind. So now you can see I'm taking a hemolog clip. This is a 13 mm hemolog. So I'm just checking, and I'm not pulling, just I'm leaving, and then I'm checking. Say I'm push the duodenum down, I leave the cystic duct, I'm checking whether any tenting of CBD is there or not. There is no tenting of CBD. I'm applying here.
Okay.
That also I'm not going down. Can you see? I'm not going down. It's no need.
Very nicely demonstrated. Yes.
Yeah.
Not pushing it down towards the CBD. Very, very nicely demonstrated.
Normal. Yes, sir. Yes, sir. So you can put a regular clip also, but a sister loaded this clip, and I put 2 clip on the CBD side. So now I'm taking this large clip. This is a 11 mm clip, otherwise called yellow color clip. So if you hold the infundibulum and if you hold it like this, you will not see the distance between the 2 clip. Okay. So for that, I do like this. Can you see, sir? So now you can see how distance is seen very well. So I can go up and then I can apply the clip. So that is the way. Reverse last clip, instead of loading like this, you can reverse it, so it will be nice. So I'm not using any energy device for this division of cystic duct. And the clipping also always, we used to keep 3 clip, and I used to name the clip routinely. So the clip on the cystic duct, CBD and cystic duct junction, that is called definitive clip. Definitive clip. When you are applying this clip, you should be very much confident that this is the cystic duct only. That is the first thing. Second thing, before applying this definitive clip, see the clip, whether it is properly loaded or not, and then just see the duct size and the clip size, whether it will match or not. Before applying clip, you have to see the 2 things. This is the definitive clip. Then this is called additional clip. The definitive clip, additional clip, distance may be maximum 3 millimeter. Then this is called sentinel clip. Between the additional and sentinel clip, 6 mm distance would be there. Is it clear, sir?
Yes.
Very clear.
And then I'm not dividing like this. Again, I may go close to the additional clip. So I rotate like this. I don't want to, I want to keep around 2 to 3 mm tissue on the CBD side, not on the patient side. So I'm just dividing like this. And then once I divide, immediately you have to see this should face laterally. It should not face anteriorly. If it is face anteriorly, that means it may be the right hepatic or the CBD. These are all the points. No, initially any mistake done, you can note it down initially. Yeah, suck. So now the job is done, and only thing we have to look for posterior branch. Most of the time, gallbladder surgery, bleeding happen from the posterior branch, not the anterior cystic branch, because anterior branch is in the view, posterior branch is will not be in the view, so it will be bowel holding. So I'm looking for a posterior branch. If it is any posterior branch is there, I don't believe any energy device. Any posterior branch, small or big, anything is there, my preference is go for a clipping. Then I proceed for a gallbladder mobilization. Okay. This also, it looks some branch, and I'm going to clip the vessel. Then I divide this with the harmonic scalpel, and then I go for a gallbladder bed removal. And any vessel here is there. Then after while mobilization, then I can able to see whether it is required any clipping or not. It looks a vessel here. After clipping this vessel, I can able to see that looks a main vessel. This is the branch vessel. So the liver is coming in the view in between, so I'm not able to coagulate. Who could try? So always look for a posterior branch in all the cases. If it is a anterior branch, this one is very small, then you can go for definitely posterior branch will be there. If anterior cystic artery is well much adequate, then you can go with the suction clip. Post-operative bleeding, everything is happened because of the posterior branch of the cystic artery. So I'm putting a medium large clip, that is a green color clip, 9 mm clip to the cystic artery. Usually the artery 7 mm white color clip is there, that is called a small clip, but that separate clip applicator is required. So most of the time we are managing with the regular medium large clip. Just the peritoneum, so much thick, no, because of the inflammation, it has become thickened.
Sir, good evening. Sandeep here, sir.
Yes, Sandeep, yeah.
Sir, this left hand traction is extremely effective way of, I think, holding the tissue. We observed it you doing multiple times, but when you highlighted, we realized the importance of it.
Yes, that is a very well point. Not only lap chole, any surgery, the surgeon is using their left hand is effectively, then he is a good laparoscopic surgeon, I can say.
Sir.
And where you are dissecting, the exposure is very important, and you can manage with your left hand. Now you can see this big artery here. Can you see this?
Yes, sir.
Yeah,
Yes.
yeah. That I am going to clip it. Then I can proceed for this one. So the left hand, and I am not holding the anterior wall of the gallbladder all the time. I am going the lateral wall of the gallbladder, sometimes posterior wall of the gallbladder. Anything can be done with the left hand instrument. கொஞ்சம் bipolar கொடுத்துரு liver
So you take the main artery or the branches, sir?
No, this is a it depends on the exposure. And if it is a main stem can be easily approachable, then I can go with the main stem. Otherwise, I can do with the branches.
This seems to
So
be
that is a little bit is gone through.
Ah, yes. Very nice.
Harmonic கொடுத்துரு. So some gap is there. There is a small branch. It's getting torn and then bleeding. I'm going to apply clip here. So I thought of encircling with the clip, but it's only this is possible. Clip கொடுத்துருச்சு. I'm not using harmonic scalpel, even though if I have, because posterior artery means always I recommend clipping. It is not applied properly because there is no posterior tissue is not there to take up the clip. But anyway, it is occluded. I am going to divide with the harmonic scalpel. So that's what I want to dissect is here. That means I can introduce the entire clip is inside.
Mhm.
The next case ready? 5 minutes. Okay. So now I'm dividing the feeding artery, posterior artery. And after division of the artery, if you have harmonic, you divide this here. After division of the artery and duct, you will have now you can see it is easily coming the posterior posterior side. Then you can have a hook. Hook is the better instrument. Suction hook, better instrument, or you can use a spatula. Initially we use spatula. Nowadays we are using hook. Anything is good one. No need for energy device, harmonic or ligature to take up the gallbladder. வாஸ் கொடுக்க முடியுமா கொஞ்சம்? So just finish the calyx, clear the field, just see whether you have done correct or not. Any doubt, if you are 100% sure, then you can go for a gallbladder. Because till then the gallbladder will be there for a traction, so that the calyx dissected area will be exposed nicely. Once you take out the gallbladder, then you are coming here means no exposure will not be there. Suck. Small bleeding is coming here. I will see after that. So this is the dissected area. Now I am going for a gallbladder mobilization. In acute condition, we can go in plane, in the cystic plate plane, so that gallbladder mesentery is there. So we will take the entire post wall of gallbladder, or we can go for a type 1 modification. Type 1 modification is leaving the liver bed, leaving the post wall of gallbladder on the liver bed. That is one thing. Suppose if a duodenum is adherent, when you are starting the surgery, duodenum is adherent, you are not able to separate the duodenum from the gallbladder, then you can leave the anterior wall of the gallbladder on the duodenum. So the type 1 modification is leaving the anterior wall of gallbladder on the duodenum, or leaving the post wall of the gallbladder on the liver bed.
Okay.
After that, excise the gallbladder, then you can go for a mucosectomy. You can remove the mucosa from the post wall or from the anterior wall. Then it is called type 1 modification. Type 2 modification, otherwise called a difficult liver bed. Type 2 is a difficult hilum. You are dividing the infundibulum, then leaving the taking the mucosa of the infundibulum, then suture the infundibulum close to the cystic duct.
Yes.
So now you can see I am going close to the gallbladder, and camera surgeon is not rotating the light cable. He is keeping it very straight only, because I want to see here. I am retracting the gallbladder. I hold the post wall of gallbladder. I am retracting it. There is no need to rotate the camera. Okay. So everything left hand is, as Sandeep told, left hand is the key for this any surgery, and left hand movement is very critical. One the surgeon should learn how to use the left hand. So
Sir.
again, I touch the gallbladder, exposure is there. I'm holding, and then I'm seeing like this. So the other side of the edge of the gallbladder I can able to see. I'm taking like this. So now I'm rotating the gallbladder like this, like this. So now I'm holding the lateral wall of the gallbladder, not the post wall, lateral wall of the gallbladder. And here it is liver bed, some is coming because I'm trying to take the entire post wall of the gallbladder. If it is a liver is getting tear, then I leave the post wall. I can have, I can take only the mucosa of the post wall. Here it's gone into deeper plane.
Oh.
So again, I shifting my left hand instrument, and you can see in the external view, my shoulder, no, it's not a shoulder strain. My shoulder is very relaxed way. I can move up and down, I can rotate my left hand sideways, and then you can see I'm not holding my left hand. If you focus close up focus on the left hand. So I'm not introducing my finger into the hole in the instrument. I'm just holding the instrument. I'm not introducing my finger into the instrument. Believer. Now see pulling out, so it will give a good exposure. So here also I'm going little on this side, I'm not going on the liver side. So here only the plane got disrupted. This looks like mucosa is coming out, serosa is left behind. Veli ilu sister?
Yes, sir.
So type 1 modification done. Veli ilu sister? Vallaya? Tokkar ilu veli first. Sure, okay. So now the entire gallbladder is taken, and here you can see some liver bed is being exposed, and I'm going to coagulate for that suction. Ready irukara ore nimisham sollitu pipe. So now you can see I'm just coagulating because bipolar is coming from my left hand, so that it will be perpendicular to the liver, parallel to the liver bed. So entire by quarter increase entire liver instrument is touching the liver surface, the coagulation will be good. If it is coming from right hand, so only the tip of the instrument will touch the liver bed, and we have to coagulation will not much effective. Is it clear, sir?
Yes,
Yes,
from
yes,
the
very
left
clear,
hand,
sir.
bipolar seems to be working well.
Yes. So I'm just chief sir is ready with the another case. Instrument bowl holding put. And another point I want to tell, when you are washing the liver bed, and so you can see I'm just retracting the left hand with a colon or a duodenum or any momentum structure here. Then the gallbladder liver bed is camera move panadra ore edathula vida. So then I retract the gallbladder like this with the suction nozzle, and then I'm irrigate the saline. The entire liver bed is washed with the saline. Once this cavity is filled, now I'm kitta pogadu ore edathula asayam. So again I'm doing like this. Can you see my left hand is, I'm not moving my left hand. I can do it, I can wash the liver bed multiple times.
Okay.
So this is the way your injury up to the colon, momentum or duodenum will be avoided. And then putting saline like this, here it is not useful. Our aim is to wash the liver bed. So entire liver bed is getting washed, and exposure is also good. I'm not injuring any structure because my left hand movement is very much minimum. So this point I want to tell. So, I think I told all the points. So any other thing you have to tell about the surgery, sir?
Nothing,
So only
sir.
thing, I'm going to put it in a plastic bag, and then I divide this into 2-3 pieces. I'm taking it already. Chief sir shown the technique, and I think you can go for a next case. Thank you so much.
Thank you.
Sir.
Excellent
That was wonderful.
demonstration.
Very nice.
Very wonderful, useful tips also. Thank you.
Thank you
sir.
so much, sir. Thank you.
Thank you, sir. Thank you all the moderators.
This lady who presented with pain abdomen for 15 days. There's no other positive history in the examination. Examination wise, per abdomen was soft. Total count was normal. Bilirubin was mildly altered. LFT was mildly altered. Ultrasound showed mildly dilated IHBRD, CVD, and CHD. A calculus in the pancreatic portion of CVD was present. So initially she was planned, and acute coli features was there. She was planned for ERCP. ERCP was done 2 days ago. Stone retrieval was done, and biliary stenting was done. Followed that, she was asymptomatic, so we are proceeding with laparoscopic cholecystectomy at present. So chief sir would be doing the case live.
Any pancreatitis?
No sir, no pancreatitis. Repeat investigation was absolutely normal. So we are proceeding with lab Korea at present.
So,
Sir, okay, sir.
am I getting it?
Hello?
Yes, sir.
Yes,
Hello.
sir.
We are with you, sir.
Yeah.
Hmm?
Yes, sir. Parliamentary, sir, we are with you.
Yeah, this is a case. See, you can see the gallbladder, no much inflammation, and now I'm retracting. You can appreciate here, and now this is a developmental adhesions. We're releasing it. Cut. Camera in the book. Hello.
Yes, sir.
Yes, sir, we can see you, sir.
Yeah. Okay. Now, see, we have the addition is released. Now, callet triangle dissection can be done. See, this is a pulsating vessel. You can appreciate.
Yes.
This is you can see CBD here. They're likely. Some edema you can appreciate because of ERCP.
Yeah.
This is a lymph node. You can appreciate this lymph node.
Yes.
And okay. Now,
reapplied the clips. Now what I'm going to do, and anterior peritoneal incision, see, now you can appreciate this is a pedicle and this is a triangle. Only peritoneum is there. This is artery. See, now peritoneum you can take this better. Who can be used after this? See, peritoneum only. Okay, hookadma. First anterior peritoneum, then posterior peritoneum. There is always doubt comes anterior first or posterior. This is where the people always look at. See, look at. See, I am taking only peritoneum. Okay.
Yes, sir.
We can see the artery. Fluid we can appreciate because of the RCP.
Yes, sir.
Now I'm going to the posterior. We can use a hook like this or take a curve. Curve we can dissect between the cystic duct and the like this. Make a space. Nothing. It is only peritoneum. Hook. So now I'm going to divide the peritoneum. Now I'm not looking for any vessels or here because only the peritoneum I'm taking it up. So now see this lymph node, and generally speaking, we should go to lateral lymph node, lateral to that. And most often that relationship all it is now no more. See, this is a posterior. You can see the sulcus. We are not going behind here.
Yes, sir.
My hand pushes the infundibulum medially. I am taking this here like this. And when you do the duodenum, don't do like this. And many report has been come, just hook injury to the duodenum. So now see, this is done. And here also, okay. So now I'm going to dissect the Callet's triangle, the tubular structures, artery and the duct. And see, now you can look at, this is where, this is vessels going to the gallbladder, infundibulum, see, dissect. So now look at, there is posterior branch, here is anterior branch. Like this. The smaller vessels is no name, no? That you can coagulate. Okay, there. See here. Hookadma. Now I am going to cystohepatic pedicle wider. Because of fluid, the artery is not just like working it. It takes time to coagulate the tissue. See, you can see the fluid, how much it is coming. Yeah. Okay, suction. Bipolar.
Suck. The smaller ooze can be controlled by bipolar. Then we have seen 2 arteries posterior, but same time we have to rule out any hepatic branch. See, we are going the other side.
Yes.
See, now we have been dissected. That is a pancreas, liver. This is one branch artery, and nothing is going to this side. So we are sure this is a cystic artery. Must be one branch posteriorly. Okay. Now I'll go to this artery also before confirming it. This curved dissector is ideally, you can. Curved edema. And don't go to the infundibulum side, dissect it. Infundibulum side go difficult. This is infundibulum. This is the cystic pedicle here. This. See, I'm just upper border. These are tissues I can coagulate. See, now cystic duct is visible. This is posterior dissection.
Or in some cases,
See, posterior, we are dissecting. See here, this is. These tissues we can cut, not this one. Okay. You can appreciate that artery. Hook. This tissue, if you take it, the artery will become very visible.
Yes, sir.
See, this branch separate, this is. And if you go here, you will come across right hepatic artery. And should not dissect here. Only the cystic duct we need. Covered.
So the wide cystic duct is possibly because of ERCP?
No, it is already stone in that dilated. Not because ERCP is, because of already stone likely to be there. That is the reason.
Stone passed below, yes.
See, now see here, and you can appreciate this posteriorly. No energy source. See here, this is a cystic CBD here.
CBD.
CBD should not skeletonize. And
Yes.
if I divide this artery,
then I can dissect little more here. See, this is one branch, that is another branch. Clip. Then after cystic duct, I can dissect little more. And closer to the clip, no energy source. But if you are wanted to dissect away from this, then you can. Safety sake, always towards CBD, have this one. So hook. Now I'm going to divide the cystic with energy, but not closer to the tip. It is going to be away from. Covered. Now I have to dissect cystic duct towards CBD to see that it is a length. And not necessarily always, but because it is dilated slightly more, we have to look at. And should not hold the cystic duct fully. Something. Bipolar. Close பண்ணிட்டு. Okay, hook. Not necessarily every case should go to CBD side, but when dilated for some reason, then we have to look at, otherwise cystic duct stone sometimes may miss. Here some vessels, not to go. Okay, come back anterior. Covered. So this is CBD enough. Now I will try to milk out towards CBD. Okay. Clip paduma. Okay. Kodama. Or Himalaya. You can see sulcus, It goes that side. There is a limit.
Yes, sir.
And this you can divide, put a loop, or a large clip you can use. But now the one clip, like the previous case, I'll use it, Hemolog. Okay, regular clip. Yeah. Must large clip, ma. Take large clip. Yeah, and what I'll do, I put this divide cystic duct, and you can go for the dissection discussion, and the rest of the thing is going to be same. I will talk to you after that. I will also come out.
Sure, sir.
Thank you,
Yeah,
sir.
sister.
Thank you so much, sir. Thank you, sir.
Yeah, thank you, sister.
Thank you, sir.
Okay. Hook. Pasupathi connect பண்ணு அந்த டாக் வேற கனெக்ட் பண்ணிடுறாங்க. விட்டுருமா விடுமா எடுத்துட்டு.
Sandeep, can you hear me? Sandeep?
Yes, Rajiv, I can hear you very well.
After a long time seeing you.
Yeah. Really long time, Rajiv. How's going there? All well?
Yeah, going well.
Great.
So my topic is just to emphasize that achieving critical view of safety is
Irrigation.
in difficult situations. I just want to show only 2 videos why critical view of safety is very important. I'll go to the first video.
Go ahead.
Irrigation பண்ணுங்க.
It was the first simple cholecystectomy. They didn't give any abnormal anatomy in ultrasound or anything. There was a multiple gallbladder stones. So as I go through the video, as I started dissecting, the anterior and posterior peritoneum was open, and I started dissecting the critical view of safety. My colleague was doing it. He had a doubt that there is some abnormal bile duct anatomy. So I had to take over the case in between. So once I started dissecting further, this was only a band. I'll show you after that. As we started dissecting the Calots triangle, whatever bile is coming in the screen is from the retraction instrument. See, you can see another duct coming from the gallbladder bed to the cystic duct. This was another duct which was seen during Calots dissection.
Yes.
So once he had a doubt, one of us had to take over the case, and we had to dissect further to find out exactly what was the anatomy. So you are able to see the artery here, and this is the accessory duct. If we would have clipped here and cut the cystic duct, we would have been in trouble. So we had to dissect further, clear the anatomy, and then we had to clip the cystic duct. So we dissected further to see where the duct, that extra duct is draining from. So it was coming from the liver bed only.
Manoj here.
Yes, sir.
Hello. Yeah.
Yes.
Did you do an intraoperative cholangiogram?
No, sir, we didn't do, sir. We didn't do intraoperative cholangiogram.
Yeah.
We
This is
dissected further to see from where the duct is draining.
this
So
is,
later, we
yeah. Did a CT?
no, sir, we didn't do any CT. This was just an intraoperative finding.
This is one of the classical most dangerous anatomy. Segment
Dangerous
5 draining to cystic duct.
Draining to cystic duct.
Yeah,
So
that
we have
has
to
been described. This is one of the most dangerous anatomical portion, especially when you take a patient for transplant.
yes, sir.
Yeah. This is very dangerous anatomy, and you're very lucky. Generally, anybody would have gone and injured that duct.
Yeah, yes, sir. Correct.
Yeah, this duct is notorious for making injuries.
So
Very nice video, fantastic.
this video
Excellent.
we recorded it just to show that not every cholecystectomy is simple. Your ultrasound might show that it's only a simple cholecystectomy, but anatomy might vary for any patient. So critical view of safety is very important. Another case I will show you where it is a really difficult cholecystectomy, but still we were able to achieve the critical view of safety. But in this case, due to difficulty in dissection, we would have clipped the artery earlier, but we dissected till the end to get the critical view of safety for cystic duct. So it was an acute gallbladder. There were lots of omental adhesions. So my opinion here is always stick to the gallbladder wall. There will be a plane between the gallbladder wall and whatever adhesions the gallbladder has. So always stick to the gallbladder wall while dissecting. Use suction and harmonic and your monopolar when and where it is required. So as I dissected further on the medial side and the lateral side, I had to bring all the adhesions down. So this patient was also on cloplet, stopped for 5 days. That's why bleeding was little higher on the side. So retraction was also a little bit tough. So slowly I could find some part of the infundibulum. So I was dissecting further down. So whatever structures away from the wall, you just stick to the wall and you have to bring that down. So use suction and monopolar and harmonic where and whenever required. So that is infundibulum. So this case especially we wanted to present that any difficult case also getting the CVS is possible.
Jugindra here. I wanted
sir.
to ask what is the protocol of usage of ICG in a GEM for a cholecystectomy?
Sir, only when we feel that the anatomy is distorted, we don't have regular use of ICG here, sir. Unless we feel that there is going to be some kind of anatomy which is going to be difficult, or Mirici syndrome, or any stone impacted in the cystic duct CBD junction, those kind of cases we use. But regular use of ICG we don't do, sir.
Okay.
So after cutting the cystic duct here, I could still further bring down the adhesions down. So there was a stone at the infundibulum. So now I was able to make out part of the cystic duct. So still after further dissection, I was able to get the window there. So yeah, In even difficult cases, achieving this view is possible. Only thing you have to be meticulous in dissection, go very close to the wall and keep dissecting further and further.
This needs a lot of training and
Yes, sir.
patience.
It's lot of training. Really lot of training. And this we can't do it at the day one. Slowly we see people doing it, and we see the planes where they are dissecting, where they are using the cautery, where they are using harmonic, at what point suction can be used, at what level suction has to be used for dissection. Everything we have to learn, and step by step only we can reach this position where critical view of safety can be achieved in such difficult cases. Thank you, sir. I just wanted to show these two videos only.
Excellent videos. To be very frank, the first case was terrifying. Oh my God, video. Oh, these type
Thank
of
you very
cases, chiefs are used to divide the gallbladder at the initial start of dissection itself. But I think now he has changed probably more of Callet's dissection.
Yes,
Those
sir.
days,
Now,
chiefs are used to
yeah.
divide it, the gallbladder somewhere in the body, then dissect. Very, very, very nice. Very nice.
Thank you, sir.
Very
Thank you,
nice
sir. Thank you.
videos. Yeah.
On behalf of our GEM hospital, I would like to invite everyone for a GEM lab research coming in November 19 to 22nd, sir. Welcome, everyone.
Definitely.
Yeah, definitely. Excellent.
Thank you very much, sir.
Yeah. Thank you.
Sandeep,
Thank you.
bye, man.
Sandeep is not seen, perhaps some network issue, probably.
Sure, sir. Okay, sir. Okay.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Have we finished, or is there some more?
I don't know. I think sir will come, and I'm not sure. Let me ask them. Where are you from?
I'm from Imphal, Manipur.
Okay. I'm from Kerala.
Malayali.
Ah, yes.